Welcome to Addressing Social Determinants of Health and Disparities through Registries and Research. Both the chat and Q&A features will be available throughout this session, so please ask questions, make comments, and stay engaged. Thank you for joining us today and for attending this session. Now I'll turn it over to Marty, the moderator, to introduce our panelists today.
Thank you, and welcome everybody. This morning, our panel will discuss strategies to collect social determinants of health data and report on disparities in clinical registries and research. Specifically, we'd like to focus on the avenues each of you have undertaken to advance the field and routinely assess and address disparities. So we'll have 3 presentations followed by Q&A. First, Dr. Moy will speak on why the data collection and reporting is important and highlight efforts at the federal level around current data collection and quality improvement efforts on social determinants of health. Dr. Murphy will provide the health system perspective and include examples of how they are connecting patients with community resources to address social and medical needs. Dr. Coe will discuss how these data can be aggregated and used in clinical registries to drive improvements and track progress. We'll begin first with Dr. Moy, who is Executive Director, Office of Health Equity at the U.S. Department of Veterans Affairs.
Hi, I'm Ernest Moy, the Executive Director of the VHA Office of Health Equity. It is my pleasure to speak with you about using data on race, ethnicity, and social determinants to improve care and research. I've spent almost all of my career studying, writing about, and talking about health disparities. 2 decades ago, I had the honor of working with Dr. Helen Burston, as well as Dr. Carolyn Clancy, who are the executive sponsors of the first National Healthcare Disparities Report at the Agency for Healthcare Research and Quality. I led the production of the first dozen of these annual reports to Congress. I came to VA almost 3 years ago because I wanted to do more than study, write, and talk about disparities. I wanted to use them to improve care. VA can and does do that, and I'm delighted to speak with you about our successes and challenges. A few quick words about my office, the VHA Office of Health Equity. We are charged with helping all veterans get the support they need to be healthy, so we look beyond healthcare to the whole veteran. Traditionally, we have tracked veteran health and healthcare based on their demographics, in the green bubble. Over time, we've appreciated the importance of a veteran's social circumstances in determining their health and have begun tracking the social determinants of health, in the blue bubble. We think that helping veterans be healthy requires understanding the interaction between who they are and where they live and work. I'm going to start by talking about VA work related to social determinants of health. This slide is from the CDC, and we see that from the big picture of lifelong health, medical care plays a modest role. Health behaviors and social determinants of health have a much larger effect over a lifetime. VA is responsible for veterans from the moment they leave military service to after they are laid to rest. Hence, we need to guide veterans to healthy lifestyles and to meet their social needs if we are to optimize their health. VA has a long history of helping veterans with social needs, although we have traditionally not labeled such work as social determinants of health. For example, VA has screened veterans for housing instability for a decade using this screener. It is a clinical reminder, which means it pops up in the electronic medical records, and providers have to complete it before they can do anything else. This has ensured very complete data for identifying veterans for interventions. These interventions include getting veterans housed through voucher programs with the Department of Housing and Urban Development and housing veterans at VAs. They include special primary care clinics that are configured for the unique needs of homeless veterans. For example, they reserve half of clinic slots for walk-ins and have specialized housing social workers in the clinic so a provider can walk a veteran from the exam room to the social worker. They include a payment system that pays clinics more for caring for complex homeless veterans. VA started similar screening for food insecurity a few years ago and has built food banks for veterans in dozens of VA hospitals. But there are holes. Because VA has thought in terms of services for homeless veterans and services for food insecure veterans, there is not coverage of all the social needs that benefit veterans. In New England, we are helping Dr. Alicia Cohen and Lauren Russell pilot this screener that includes assessing need for help with utilities, transportation, legal services, intimate partner violence, social isolation, employment, and education. Veterans who screen positive are given local resource guides specific to each need, or referred to social work if the need is great. I do appreciate that part of the reason we can do this is because veterans have access to special benefits. Veterans in need of education can use their GI Bill benefits. There are many special programs to help veterans get hired or diverted out of the penal system and into VA rehabilitation. Our veteran service organizations provide many opportunities for veterans to socialize. I would generally not ask about social determinants of health that we could not address in some way. So what have we learned about using screening for social determinants of health to improve the well-being of veterans? Screening works and facilitates housing veterans. VA has housed 600,000 veterans and their families since 2010 and reduced the number of homeless veterans by half. Use of our homeless primary care units has been shown to lead to 25% fewer ER visits and admissions. Our broad social determinants of health screening has revealed the high prevalence of social needs, especially social isolation, and among women in our urban clinics. So far, I've spoken with you about using social determinants of health to improve care for veterans with extreme social needs. We can certainly see how being homeless can affect the veteran's health. Because homeless veterans are disproportionately veterans of color, we can also see how homelessness can contribute to racial and ethnic disparities in health among veterans. I'm not going to talk about VA research on racial and ethnic disparities because there is so much of it, but I will summarize a few key points. First, VA has good data on race and ethnicity among veterans receiving care in VA. We have race or ethnicity data on about 90% of veterans served and have studied disparities for decades. Second, there are few disparities in processes of healthcare in VA. For example, receipt of preventive care and indicated services for diabetes are the same across most racial and ethnic groups. Third, where we do see differences are in outcomes of care and veteran experiences with care. Despite getting the same services, veterans of color achieve poor control of diabetes and hypertension and report more problems in interactions with VA, particularly VA front office staff. I think social circumstances play an important role in disparities, but the vast majority of veterans experiencing disparities are not homeless. They do not have poorly controlled diabetes or hypertension because they don't have a roof or food. They typically have homes, jobs, spouses, friends, hobbies. They keep their appointments at VA and get the services they need, but yet they have poorer health. Why? VA tends to think of our veterans as a homogeneous population. To improve diet, the same counseling and handouts are provided across our system. To promote exercise, the same curriculum and workbooks are used in Maine and in California. Because all veterans speak some English, translated documents are rare. VA tends to think that this one-size-fits-all approach ensures equity. I think it has the opposite effect. What works for the average veteran, an older white suburban male, may not work as well for other veterans. Younger, female, minority, inner-city, and rural veterans may have subtly different social circumstances that make customized counseling and outreach more effective. Advice about diet and exercise might be more likely to be used if tailored to where a veteran lives and works, and delivered in the context of a trusting, respectful patient-provider relationship. How do we engage VAs to actively seek to pay more attention to social determinants and reduce disparities in health? One thing I've learned is that many people like to talk about disparities as a social justice issue in general, but when that lens is applied to their facility, clinic, or care, they tend to get more defensive. Are you racist? Is not a good way to start a conversation about disparities. Instead, we leverage the existing quality improvement processes that already exist in all VAs. VAs are tracked on a wide range of performance metrics and expected to act when they underperform. We tap into those processes. Our approach, which we call an Equity Guided Improvement Strategy, or AEGIS, starts with the question, do you serve a homogeneous population or a heterogeneous population? Some VAs do serve very homogeneous populations, and we give them a pass. Equity has little to offer. But most VAs serve heterogeneous populations. We work with these VAs to figure out if their underperformance on a specific metric is distributed evenly across their population or concentrated in a specific group. If they serve a homogeneous population or underperformance is evenly distributed, standard quality improvement processes are appropriate to shift performance closer to the target, as illustrated on the left here. However, if underperformance is mostly due to care received by a specific population, as illustrated on the right, we think this has important implications for quality improvement. First, the facility should not fundamentally rework its processes. It knows how to achieve good performance. What they do now works with some groups. They should not disrupt these patients by changing the processes. Rather, they should tweak these processes so that they work for the group with poorer health, perhaps by tailoring or supplementing processes for members of this group. This equity-guided improvement strategy has advantages. Quality improvement resources can be focused on the group with poorer health, rather than spread out over everyone. And there may be common social circumstances that are more efficient to address across a facility or clinic rather than by individual providers. For example, if language is the issue, patient information could be translated for all providers to use rather than having each individual provider use a translator to communicate that information. If the group lives in the same neighborhood, common with residential segregation, patient information on shopping for healthy food or exercising in that neighborhood could be made centrally rather than by individual providers. If peer supports would be helpful, this would be more efficient to organize at the facility or clinic level. This is the logic for our approach that was developed by Dr. Leslie Hausman at VA Pittsburgh. She worked with clinic managers and quality improvement staff to identify the key decisions that would lead to appropriate use of the equity-guided improvement strategy. First, are we underperforming on the metric? If no, there's little motivation to change. Next, does a disparity exist? Is there a disparity group that uniquely underperforms? Is that group big enough to make a difference? If yes to all, then AEGIS is appropriate for this site for this measure. This is a dashboard we developed to support this logic. For a variety of performance metrics already tracked in VA, this first page is used to identify those VA medical centers whose performance is below the top quartile of facilities. These underperformance are then the target audience we want to reach. This second page then shows performance for each racial and ethnic group. On the left panel, each horizontal series of dots is a VA facility, and each dot represents a racial or ethnic group. Brown dots are white veterans, light blue dots are black veterans, and green dots are Hispanic veterans. The vertical line is the performance of top quartile facilities. You can see that there is disparity in the metric shown here, blood pressure control, in many VA facilities. We are looking for the ones with large variation and on the left side of the target line. On the right panel, we bring in numbers of affected patients to calculate how much the care received by a specific group contributes to overall facility underperformance on this metric. We can see that for several VAs, a big chunk of underperformance could be fixed if they raise a group, black veterans in blue or Hispanic veterans in green, up to the target level. These are the groups we would recommend targeting for quality improvement. We used the previous dashboard to convince leaders and clinic managers to use an equity-guided improvement strategy. When they buy in, this is the dashboard for staff in the clinic. It is not as colorful, but much more functional. For example, if looking at blood pressure control, parts of this dashboard let the manager identify the individual patients with poor blood pressure control. Parts link to successful interventions for helping minority patients improve blood pressure control, and other parts track change in this metric over time. I focused on how my office uses data on race, ethnicity, and social determinants to improve care, because that is most of what my office does. Did want to mention our work to support the inclusion of veterans of color in clinical research. This is a link to a series of videos created with the FDA to encourage veterans of color to continue serving our nation by participating in clinical trials. This is particularly needed now as treatments and vaccines for COVID are being tested. We want to make sure they work well for all veterans. This concludes my remarks. I hope you are motivated to explore how you can use information on race, ethnicity, and social determinants to improve care and research. In addition to advancing social justice, I think an equity-guided improvement strategy supports a more efficient use of quality improvement effort and resources. I welcome any suggestions you may have about how we can improve our work. Thank you for your attention.
Thank you so much, Dr. Moy. We appreciate very much your contributing to our conversation today. I'm pleased to say that we will next hear from Dr. Karen Murphy Executive Vice President and Chief Innovation Officer at Geisinger. Thank you.
Thank you, Marty, and thanks for having me here today to represent Geisinger, and thanks to Dr. Moy for such a great presentation and all the work that you're doing for the VA. So today I'd like to talk about the activities that we're doing at Geisinger in social determinants of health as an integrated delivery network. Next slide, please. So just to talk a little bit about Geisinger, we're located in our main site is central Pennsylvania, but we're really in 55 of the 67 counties across Pennsylvania. So we're an integrated delivery network in that we have 11 hospital campuses, 261 clinic sites, 3,200 employed providers, and then we also offer insurance. So we have close to 500,000 members and 56,000 contracted providers and facilities across Pennsylvania. So both Geisinger and non-Geisinger providers in the health plan. And then we teach, research, and innovate. So you can see the number of medical school students that we have at our medical college. We have nursing students. We have a research portfolio, and then I lead the Steele Institute for Health Innovation. Next slide, please. So we'd like to talk about the Geisinger difference in that it is integrated care and coverage. So the one of the advantages of having a health plan that's within the enterprise of Geisinger is that it allows us to really match the care and coverage model. And we have found that when we insure a patient and also provide their health care, that we can improve the quality outcomes at a lower cost. So our focus is definitely on quality, and we've really moved to value as opposed to looking at volume. And we have a continual focus on the patient member experience. Next slide, please. So when we talk about social determinants of health and looking at it from a health system perspective, it has become very clear to us that it is very important for us to look at physical behavioral health, and also the social determinants of health. However, we have also recognized that we have to address the social determinants of health by developing community partnerships. So throughout our footprint, we have been very actively seeking out community partnerships to address the social determinants of health. It is highly unlikely that any health system is going to be able to, or should really, address all the social determinants of health. We have community and social service organizations that have both the expertise, the deep knowledge, and they have their mission and focus on social determinants of health. So we think that the best approach is really to create partnerships and collaborations with community partnerships. And then what we bring is the health system perspective. We bring in the resources that we have throughout the enterprise that certainly embraces innovation, technology, and really being the connector for those organizations with our patients and members. Next slide, please. So what's our social determinant strategy? So number one, we're data-driven. So we have to understand the data that identifies patients that need, that really require social determinants. I'm going to talk about EPIC and Neighborly in more depth in a couple of slides, but we also use our community needs assessments that we do in all the communities that we serve, because Community needs assessment provides a really rich detail on what the state of the community is and what the needs of the residents of that community are important. Just to give a couple of examples, as I said, we're very strongly supporting the philosophy that we need to support community partnerships and develop community partnerships. They are social service agencies, food banks, and transportation providers, just to name a few. And then sustainable outcomes. We have to measure, evaluate, iterate, measure, evaluate, and iterate. This is a really important piece, I believe, of addressing the social determinants of health. But I also think it's really important to understand, and sometimes, quite frankly, it becomes difficult because many of the outcomes, the health outcomes that we look by addressing social determinants are really long-term impacts. And, you know, I always say in healthcare, we've, for a long time, we expect short-term results from long-term strategies. So I think in social determinants of health, it's not as easy to evaluate, but we always try to put some type of evaluation paradigm in so that we could see where we're being successful and really change what we're doing based on the outcomes. Next slide, please. So this is an example of how we use data. We have screening questions embedded in our EPIC electronic health record. So this is just the example of us screening for food insecurity, and we screen all patients. So this is a very important source of data for us as we develop our social determinant strategy. Next slide, please. So we use Aunt Bertha, which we have named Neighborly, to actually develop a database where providers and patients can actually search all of the zip codes in the Geisinger area. We have listed over close to 9,000 programs, community services, and partners that can be used to connect the social services with our patients and members of the community. We have it embedded in our members and patients My Chart or My Geisinger. And, you know, we launched it, we were planning a much slower launch, but when the pandemic hit, we decided that we weren't going to do this really long launch. While we tested, we thought that it was very important to get it out to those in our community that could benefit from the information. So we did a large launch in March of 2020. Next slide, please. So I think we were even taken aback by the quick uptake of Neighborly. You can see the statistics there. I think the one that grabbed me, and it was during the pandemic, we went as high as almost 60% at one point of individuals looking for food. And it was, I never would have anticipated that it would be that high. So food insecurity obviously is a real need in our communities. And as I said, we do partner with food banks to really serve that community need, but also looking for housing, health care delivery, and other goods on the Neighborly program. Next slide. So I thought I'd take a minute and go through some of the programs that we are piloting and looking at. We have several programs in social determinants of health. So I've just picked out a few that I'd like to talk about. The first is housing. I think this one is really, really challenging because I think that we really have to address the housing crisis, the homelessness, the homeless crisis. I think we really have to address that as really a country, and come together with our policymakers overall, having spent time in policy. I think this is something that no one health system or Medicaid provider or health plan is really going to address. You may house a few, but to look at it on a large scale, I think as a country, we have to come together to really address this issue. Having said that, we do have members of our community that do come to us in a very challenged way, looking for housing. So we've decided to focus on Medicare Advantage, so they're senior citizens. How can we partner with high rises and other types of senior living at finding housing, but number two, also improving housing conditions and a way to keep elderly in the home and to prevent falls, provide food, so they're living on their own. So really addressing not only securing housing, but also housing once they have their home, actually addressing the housing conditions. Next slide, please. So this is one of my favorite programs. We started this almost 2 years ago. So it's a program for moms to stay in recovery. So we have a really severe substance abuse disorder program or problem within our footprint, like across the country, really opioid use disorder among moms that are pregnant, and then the subsequent sequelae of babies being born addicted. So we have a very large medication assisted treatment program across the Geisinger footprint. And we said, while we have this population that are coming to the medication assisted program, we could then engage the moms at that point as soon as they enter treatment and just wrap our arms around them with community services. And that's exactly what we're doing. So it's not a healthcare program. It is really a program of supporting moms with social services. And we buy diapers, we buy food, we do anything to support that mom to maintain her recovery. And then we also support after the delivery of the baby. We also support with early childhood intervention, and really just trying to support both the mom and the baby so that they can so that the mom can stay with the baby and really thrive in recovery. Next slide, please. We do transportation pretty much, in looking at, we have a high need for transportation. And I mentioned monitoring quality outcomes. And this one is interesting because we've had a very difficult time evaluating the effectiveness of the program in terms of impact on health. And really why that is it is because we're doing so many other interventions with our patients that need the transportation that it's really hard to tease out transportation as being the isolated event that really translated into a change in health status. But what we have decided was that with the number of trips that we've done, that it is an area that we think of need and that we should serve our population accordingly. So we've continued with our 4-ride transportation program. Next slide. Our Fresh Food Pharmacy digital suite is the newest addition to our Fresh Food Pharmacy. So you may have read about our Fresh Food Pharmacy. At Geisinger, we developed a program that we prescribe food for type 2 food insecure diabetics. We have seen amazing results. So the doctor writes a prescription, go to the Fresh Food Pharmacy. The patient enters the Fresh Food Pharmacy, and we begin with diet counseling It's a physical location. We begin with diet counseling, health coaches, and really provide food recipes, cooking lessons, provide food to those that are food insecure and are diabetic. And we have we've had amazing results. So we've taken that program and created a mobile application. And really what we're looking at doing now is rapidly expanding the program to work with other food banks and really working with those that are food insecure to try to improve their health. So we're really excited about this and hope that we will have some pretty good results to share shortly. Next slide, please. And I think this is my last slide, and I think this is a different approach. So we're even supporting GED for those that never finished high school. Our Medicaid population within our Geisinger health plan, we are supporting them in taking the GED exam because we feel that the further they can move on the education spectrum, the more likely they will be to get a job that is sustainable for the member and their family. So we're really trying to look at social determinants of health, economics, nature of a community, economic infrastructure of a community, really trying to look in a way beyond what we've thought about so far. So thanks very much. It was a pleasure to share our work with you today.
Thank you, Dr. Murphy, for those very interesting examples of community resources that address the medical needs for patients. Our next speaker is Dr. Cliff Coe, Director of the Division of Research in Optimal Patient Care at the American College of Surgeons and Vice Chair and Professor of Surgery and Health Services at UCLA. Thank you, Dr. Coe.
Great, thank you, Marty. Good morning, good afternoon, good morning, everybody. Welcome to this session on addressing social determinants. I'll be talking about this as discussing how these social determinants of health data can be aggregated in clinical registries. And I think that it's going to build very nicely on what Dr. Moy and Dr. Murphy has said is in two of the leading systems in our country of providing health and healthcare, the VA and Geisinger. And I think that it also aligns with what CMSS wants to do in terms of the mission of educating and improving quality and the professionalism of the providers participating and supporting healthcare, but also populational health. And I think that the social determinants are increasingly being recognized and addressed in the ways that Dr. Moy and Dr. Murphy have said in their systems and throughout the country. And really, I think my talk is really to focus on the aspect that is really important for anything that we want to move the needle on is getting data so that we know where we are, we know what our gaps are, and we know when we're moving in the right direction. And I think that's what gets often confusing is that the data that we get is so parsed out into different silos, and that we really need to better unite all these things together so that we can act on them and have programs like both prior speakers talked about. So I'm going to try to discuss how we can look at social determinants of health data and whether we get them in our clinical registries or our EHRs, and we're merging them in, or we're collecting them as primary data. How do we collect it, and things to think about in that regard. So let me move forward. May I have the next slide, please? Here's the big question. Can we collect, analyze, and use social determinants of health data to drive improvements and track progress? And I think obviously the answer is yes. Next slide, please. And I was asked to talk about registries because I think that many of the members of CMSS have registries or are developing registries or have multiple registries. And as we all come together and in prior talks and sessions, there are many registries with many functions. So a lot of our registries focus on patient care. Often these same data are used for research. Sometimes they're used for regulatory or performance measure, data collection and delivery to various folks. Often they're used for quality improvements. There's obviously other reasons, and a lot of times our registries are used for a combination of these things. And the question again is, will social determinants of health data contribute? And I think that a lot of registries that I see when I look at their variable list, they do not have enough of the social determinants data. And so will it contribute having this data put in? Absolutely, yes. Next slide, please. So this is not really a talk on how to develop a registry, but some certain things to think about are what's the context of social determinants on the registry focus, whether the registry focus is disease-based, like a cancer registry, or treatment-based, like a surgical registry, the population of patients, inpatient, outpatient, a health system, or if it's really population-based and we're just kind of a broad swatch of just the location of a city, a state, a region, and how would we get social determinants in there, and how do we integrate it into the data? As we start to think about that, especially for the more targeted registries that look at health care over more so than kind of the population aspect, what variables will we use, and do these variables have definitions? I think all of us who have registries have learned that if we have a lot of variables with not such great definitions or no definitions, and just expect the people to understand, oh, I kind of know what that is. You know it when you see it. We often get very difficult data to analyze, and a lot of times the results of that analysis are sometimes suspect. Another issue is comprehensiveness versus parsimony. Just from what Dr. Moy and Dr. Murphy have talked about, there's a number of ways to measure it. There's a number of granularity levels to go into to measure these things. And so it could be very comprehensive. And that gets to the next thing of how can we automate these, or is it a burden to collect this data? If we have people on the front lines asking 5 questions or 15 questions or 45 questions, there's a difference there. I think what we're learning across the country is the more we can standardize and put things together and have one way of looking at things, if we can agree on that, the better. We have faced many times where we take one topic area and define it multiple different ways, and it's not standardized, and it's the apple oranges type of thing. And so these are some issues in terms of moving forward with social determinants of health, and how do we really become data driven and beyond what my hospital does, or the neighboring hospitals in Los Angeles, or in the state of California, or in the West Coast, or anything like that. How can we learn from each other? And a lot of that will take some level of standardization. The third piece is merging and combining data sets, and I want to focus on this because I think that this is a great option for us all to consider, in terms of what people have coined big data. If we can take what we do in our disease-based registry or our treatment-based registry and merge in social determinants of health from other registries or collection avenues that do it well, that brings kind of a synergistic a relationship between registries, and hence adding up into big data. So may I get the next slide, please? So as we all know, there's an ongoing increase in sources of data, information, and even in analytics. A couple of years ago, I was told there are 300 plus registries, and a lot of them new in the past 5 years or so in healthcare, in CMSS in healthcare. And of course, these other things, these graphs, these spreadsheets, and the old-fashioned computer-looking things are supposed to be representative of EHR. So if we look at our EHRs and our registries, that's a lot of times in healthcare, the health delivery system for the more traditional way of looking at things. That's where we get our data. Next slide, please. However, if you think about all the other aspects of our avenues of potential data that we can get, are getting, should be getting, it's a lot of these things. So I don't have a pointer, but if you look on the left of, we have mobile technology that we're wearing. My phone, my watch tells me how much I sleep, what time I wake up. Increasingly, whether I'm eating healthy or not eating healthy, other things such as alcohol or other things like that, activity levels, even just simple ambulation are being measured. Of course, the next kind of moving from left to right, medications are increasingly being obviously collected and put into these databases, as is our health. Even our watches now can give us an EKG lead read to know if we're what our heart rate is, or even if we're in what type of rhythm we have. Our vitals, our radiology is coming into this, our weight. The yellow double helix DNA there is just one icon, but it is a huge thing with the Genome Project and all the genetic information that helps us to possibly predict, prognosticate disease and outcomes. That's a huge piece right there. And we're starting to get a lot of this data into our systems, or merging it in. This last row of, where you live, your socioeconomic status, and education, things that are included in social determinants. All these things together are making up big data. I would dare say that, that last piece of even the location where you live is becoming increasingly important as we prognosticate. There are studies out there where life expectancy of zip codes that are just 3 miles apart, the life expectancy can be as much as 20 years different. And so as we need to get this data, we need to get the data in context of all this other data to see how these things are going. Perhaps even zip code would have, in that regard, has a larger influence than genetics. And so we have to really respect that, collect that data, evaluate it, study it, act on it. Next slide, please. So once we get all this data together, and this is what, I think that leadership of members of CMSS and others, we get this data, we put it into the proverbial cloud, and then we need to act on it. So the data should come back to our phones, our tablets, our laptops as we're working with patients or in the community. There's obviously ways to study it and research it and put it into books and journals and papers. Next slide, please, because we ultimately want to improve the health and healthcare in our neighborhoods and with our folks within those places. And so I think that this is probably preaching to the choir that we need to get this data, and really the bigger focus across the board is probably what we should be aiming for. And I think that this session is really targeting that in an important way. Next, please. So what and how might we collect social determinants of health data? We've heard from Dr. Moy and Dr. Murphy how they do it in the VA and Geisinger respectively. There are so many different ways, there's many options, but I just want to leave kind of you with two things that I think are potential ways of doing it. Certainly this is not an exhaustive list, and there are many collection tools out there, but I thought these two were very interesting. So I'm going to talk about Icd codes and secondary and primary and second primary data collection. Next slide, please. So the first option is Icd codes. In 2000, I think it was 16, the Z codes were released, which they're a subset of the ICD-10 codes, and they're kind of used as quote unquote reason codes to capture factors that influence health status and contact with health services. They apply to all healthcare settings. They are not primary codes. They have to be accompanied by a procedure code. So it's not only the Z codes, but the Z codes come along with the procedure codes. Again, they were released in 2016. Next slide, please. There are 9 categories of Z codes, and I don't know if this is too small for you to see. I think these slides would be made available, or just Google Z codes. But here are the 9 categories. Z55 is about education and literacy. 56 is about unemployment. 57 is occupational risk factors. 59 is about housing and economic circumstances. Z60 is the social environment. Next slide, please. 62 is the upbringing, 63, 64, 65, and you can see those. So this was done by CMS with a host of the expert panel on this was a lot of the who's who and a lot of thought leaders in terms of bringing this together and validating these definitions and tools. Next slide, please. And it gets even more granular. Each of these 9 categories has subcodes. And so altogether, the 9 categories and all the subcodes, there are 97 granular codes in total. So as an example, Z55, which is related to education and literacy, has 7 subcodes. And so it's Z55.0, 1, 2, 3, 4, 8, 9, and you can see what they are here. So they tried to get, at least address some of the important social determinants, and then kind of tried to get as granular. So initially, when we were talking about what are the variables and how to standardize them and with definitions, this is an attempt to do it through Icd codes and the Z codes. Next slide, please. They launched this in 2016, and so it had a start. And so they looked at the Medicare beneficiaries in 2017 of the 33 million. There was just at the start of the program, 1.4% had claims with Z codes, which is about 500,000 patients. And you can see that the 5 most utilized Z codes were homelessness, problems with living alone, death of a family member, problems with psychosocial circumstances, and then problems with spouse-partner relationship. I don't know if there's been any more subsequent data. I haven't been able to find any, but I'm sure there is. But I expect that rate to go up. I think that I've seen within healthcare systems, they've really incentivized their providers to start using Z codes, so that even if in the country it's not uniformly equally used in a system, it could be used, and it could be used in a way that if it's in the system, then it could be taken out and things could be much more data driven. Next, please. Disparities, as you might expect, would be demonstrated by Z codes, and so this is just 2 examples. Homelessness. There's been a higher utilization of in males and females. All other Z codes were higher in females and males, and there's significant disparities in again the homelessness amongst certain race ethnicities. Next, please. So that was the Z code and Icd code way of doing it. Another option is primary data collection. There's a number of screening tools out there, and I know that the 2 prior speakers talked about some. This is the HRSN, the Health Related Social Needs, and this is a 10-item screening tool. There are core questions and supplemental questions. I'm sorry, I misspoke about the ICDs. Those were not done by CMS. This was done by CMS. This is the core questions address housing, food insecurity, transportation, interpersonal safety, and utility. And then you can see the supplemental questions there, the topics. Next, please. I won't go read all these, but there's, and maybe we can go through these next, please. Living situation, these are the questions. The food, were you worried about the food would run out and the food that you just bought didn't last you, you didn't have money to get more? Those are food items. Next, please. Transportation, you can see that the lack of transportation to getting medical appointments. Utilities, that these things were shut off. Next, please. There are safety questions. Here's the first one. Abuse happens. Anyone in your family physically hurt you. Next, please. And then these are the remaining 3. And then you can see the scoring is pretty easy, and it shows when a person might not be safe or having issues with social determinants. Next, please. The supplemental questions, I think also, when I didn't put them into the talk, it'd be too long, but you can find them pretty easily. But these are also very important things. And I think that for what we're thinking about in terms of social determinants, these are important things to ask depending on your locale and your population and your patients. Next, please. So I'm going to end here. Thanks very much. I think our overarching goal is really to figure out how we can even better aggregate and use data to drive improvements and track progress in populational health and public health and in our health delivery. And those things should not be looked at as separately, but really all together. And the more that we can put data together and include the essential pieces, which are the social determinants, I think that's going to be really helpful for our progress as we move forward. So thanks very much. Thank you.
Thank you, Dr. Coe. And while we're going to invite questions, please put your questions in the chat so that we can call on them. But let me start, Dr. Coe, while you're just having completed your talk. Thank you very much. You've given us some good examples of tools that can be used for collecting these data. But you've also said that there's a need for standardization. Are you aware of any efforts to standardize? You know, is this a role for CMSS, for example, or is there an effort to try to figure out how all of these new registries that are now going to be highly motivated, if they don't already, to collect this kind of information, how they can design the system so that they're not going to be continually having to adjust to what evolves as the standard?
Yeah, well, that's a great question. And it's always this this idea of standardization versus, you know, individuality and uniqueness and innovation. And I think that the idea of the big data merging of data pieces together is a good way to keep things standardized, where, you know, if an organization has their registry, rather than adding what they think is going to be the right thing to it, merging it with a different data set, if that's possible. I think the ICD is a definite way if a registry can put in codes that way. But there's certainly a number of other types of data sources that can be merged in. Indices, the CNI, the Community Needs Index, Area Deprivation Index, things like that. But I'm sure that the other Dr. Moy and Dr. Murphy can add in their thoughts as well.
So I think we're finding out that particularly in this area, we've had a lot of concerns of a lack of standardization from community to community, from the state, you know, looking at it's just so much more costly when you're lacking that standardization. I think the other cost is not only from the technical standpoint, but also the ability to evolve and iterate and lessons learned. So if everybody was on or approached this similarly, we would all learn a lot faster, right? Because we could share lessons learned. The N is bigger to study. So, you know, I think we've done this constantly throughout healthcare. Is, you know, really electronic health record is a great example of, you know, it's an electronic filing cabinet because we don't talk. So, yeah, we would strongly support standardization.
Dr. Moy?
I think he's frozen.
I think, yeah, unfortunately, I think he's frozen.
Oh, he's back. You're on mute.
There we
though.
go. Dr. Moy, you're on mute. We can't hear you. Maybe we'll have to. Maybe we'll have to go to one of the next questions while Dr. Moy adjusts his microphone. So there's a question from Janice Tuft to all the panelists, and the question is, what does the group see about HL7 and at-gravity project for the future standardization opportunities? I guess that's kind of a follow-up question. Dr. Moy, do we want to see if you can answer that, if you've got microphones working? Okay. Dr. Coe or Dr. Murphy, would one of you like to take that?
Yeah, so I'm not all that familiar with the at-gravity project, but I think that the HL7 is a great way to standardize the way things are going. And the hard thing about, I think, standardization is that everyone agrees that it works for them. And so, you know, as I know that our experience in dealing with HL7 has been that as we've tried to do it, and other societies collecting similar data try to do it, and when we work with our hospitals or our systems, if they can do it in that way, and sometimes it works great, and if it works great for 2/3 of them, you know, is that where we could do, because getting 100% buy-in is not something that we've been able to do regularly. So HL7 is a great way to do that.
Then another question is, someone said, Dr. Moy, maybe you can write a response in the chat since we are not able to hear you. Another question is, PRAPARE, P-R-A-P-A-R-E, is a commonly used standardized data determinants of health collection that is integrated with most EHR systems. I'll take that as a comment more than a question. Dr. Murphy, I wanted to ask you, you shared information about, you know, rapidly standing up, I think it's called Neighborly. But comments in general about how do you motivate and engage disadvantaged people in communities to participate? It sounded like one way to do it is to pick something that they really care about at the right moment. But could you elaborate on that a bit?
And I think to be honest, it's a work in progress. So we're not there yet in terms of, I mean, you saw the numbers, which were certainly we felt during the pandemic demonstrated that we're on the right track, but we have a long way to go to get the engagement that we need with Neighborly. But the way we're going to go about it is really trying to start at the point of a provider to be able to do that screening process that I talked about, and then being able to say and introduce the member to Neighborly, have the office be able, the physician's office actually be able to say, if they recognize in the screening tool that there's a problem, have them be able to also say to the member, here's a resource for you, and let's look and see what's here and get you started. But we're, you know, I think we had a great start, but we have a ways to go to really make sure that the tool is really reaching everyone that we need to reach.
Well, unfortunately, we're already at the end of our time. Dr. Moy was the person who submitted the PRAPARE information that's in the chat, so thank you. Thanks to all of you for participating today. These were very, very interesting presentations, and I know CMSS is going to be trying to continue the conversation after today with ongoing opportunities for Q&As. So thank you very much. And to everybody who's joined today, please don't forget that you have the opportunity to go to the Industry Partners Hall. In the next hour, that time is set aside for you to be able to do that. We want to thank our partners and have the chance to talk with them during this time. Thank you so much, everybody.
Thank you.
Bye. Take care.